So what to do when a patient misrepresents an injury? And this may be intentional or not. It may be a situation where there's an off-the-job injury that's reported as an industrial injury, or it may be a job-related problem that's represented as non-industrial for some reason. So when this comes to our attention, what do we do about this situation? It's not so much an issue of care, what ought to be done for the patient medically, but how do we handle these from a kind of an administrative standpoint? So here's one situation. In August, early August of last year, a patient had an earlier visit on 7/19 and came in on 8/1 as a follow-up with a closed nasal fracture with some obvious deviation. And when he had come in previously, he said that the injury was from wrestling with his brother at home, didn't represent it as an industrial injury. But on follow-up, the patient said he had lied because he was embarrassed about how it had occurred at work. He reported that rather, when he was raising a landing gear for a truck driver, he was rotating it improperly fast, resulting in being hit on the nose with the metal handle. So raising the trailer tongue and trying to disengage it apparently from the tractor, hit his nose with the handle. Suffered epistaxis for the first 3 days, which resolved. No difficulty in breathing or congestion. His primary concern was notable deformity with deviation of the nose to the left. So he had a cosmetic injury that was not producing a respiratory problem. He says he notified his supervisor the same day and wanted to consider the injury job related. Not quite clear what day that was, he said, but nevertheless, along the way determined that he wanted to consider this job related, fessed up to what actually happened. And so the question is, what do you do in a situation like this? Andrew, are you with us at this point?
Yeah, I'm here.
Great. So what was going through your mind when you saw this fellow with the nasal deformity and the change in what the etiology of the injury was?
The nasal deformity was obvious. That part we can't refute. What was documented on the prior visit was at our own clinic as an urgent care visit. And so I just have to go by what the patient said on that visit for the workers' comp case. And I documented as if it was a workers' comp claim, trusting his word. And I would leave it for the workers' comp carrier and the employer to investigate and see which story is correct.
And that's right. And that was exactly right. In a situation like this, for starters, we're not the police. And so what we want to be doing is providing the best possible care. We do need to render opinions about causation. That's part of our AOA, COA decision, of course, but that's always based on what the patient says. And so in a situation like this, where at a subsequent visit, the story changes, and is it going to be managed as group health, or is it going to be managed as work comp, or is there some other issue similar to that? But in this case, that was the question. How is that to be determined? What do we do to how do we worry about that? So it's, as Andrew said, the burden's really on the patient to convince the employer and the carrier of whatever happened or what the dates are. And of course, there's the piece of it from the employer standpoint where they need to acquiesce, and employer sends in the employer's first report and represents it as they believe it happened. And sometimes, of course, there are disputes between the employer and the patient. Some cases, the patient will early on say that something happened on the job, but it was unwitnessed. Nobody saw it. He or she was by themselves. And so the question is, did it happen on the job, or is it a case like this, the report later was job related? So we really leave it up to the employer and carrier to make that decision. The patient needs to talk to the employer, explain what the truth of it is, whatever that happened to have been, and then let the employer and the carrier decide, if they accept that. Now, the case is, you remember from prior discussions, can be put on delay. When there's a question, the carrier's got 90 days to make a decision. And in occasions where there's questions, they'll interview the patient and gather whatever other information they feel they need to have, and then make a decision about it. But that's where the case lies. It doesn't make a lot of difference from our standpoint what the etiology was. We have some different reporting requirements under work comp. We've got to follow MTUS, but by and large, we're going to treat the patient the same way. If we're going to make a referral to a specialist in a case like this to correct the nasal deformity, then of course we need to know. Well, we always want to know who the payer is going to be, but the specialist particularly is going to want to know who the payer is going to be. So all that has to be worked out before the patient's referred anywhere. So we leave it to the employer, and then be sure that the employer and the carrier accept it. If somebody's in the car, if you could mute the phone, please mute your phone. So the employer and carrier have to accept the claim. And what we need is to be sure that we're using the same date of injury as the employer and carrier, because part of the filing, of course, in work comp claims is by date of injury. So we need to share the date of injury that the carrier, or we need to use the date of injury the carrier and the employer are using. And then in a case like this, and if everybody could mute, somebody, you can mute your phones. 332-6568. If you could mute your phone, please. What we would do then is convert the claim to work comp and complete a DFR, and then further care as work comp. And we would manage it unless there's direction otherwise, the first visit that's determined it's no longer group health, but it's a work comp, that we would fill out the doctor's first report on that date and send it in. So that was exactly the right way to do this. Now, as it happens, the group health carrier, if sometimes these things go a long way down the road, and there may be specialty visits for under group health, there may be imaging or other expensive things. The group health carrier may recover their costs through subrogation. They may subrogate to the work comp carrier and be reimbursed, or the reverse may happen. If this starts off as group health, as a work comp claim, and it's later determined to be group health, sometimes the work comp carrier can subrogate. So, but that's all gets worked out on their end. That doesn't affect us at all. Now, this applies to several situations where there can be different circumstances. Sometimes the patient doesn't know if something's job related or not, and so files or seeks care under group health with their family physician in good faith, thinking that it was job related, and then it turns out it isn't. Where I've seen some of those are repetitive strain type symptoms, carpal tunnel, and then the family physician decides, well, this was really job related as a data processing person or a construction person using vibratory equipment. So it may get switched along the way, but it's not. It was an honest mistake, or it was unknown to the patient at the outset. Sometimes there are cases where patients may suspect they have a job-related problem, but they want to do it under group health. But then down the road, when the costs are going to start piling up, for example, surgery may be indicated. The group health may have a deductible and a copay. Then the patient decides, and there's no, of course, in group health, there's no wage replacement. Sometimes the patient will decide they really want to call it job related. It's an equivocal case. It comes up under those circumstances. Sometimes early on, the supervisor or someone else at the company tells the patient to file it under group health. Don't do it as job related, because of cost to the employer, experience modification and their premium. That kind of situation can occur, obviously not the patient's fault. And then again, wage replacement when it's done under group health. So there could be a variety of circumstances under which this kind of question can come up. But the answer is always, when you get with whatever information you have, you represent it as you see it. And if circumstances change, particularly again related to who the payer is, then let the employer and carrier know, and they can decide, what they're going to do. So again, the burden's on the patient to convince the employer and payer, and just be sure that we're using the same date of injury that everybody else, that the other parties are using.